Good afternoon, everyone. Respected senior faculty, students, and my dear colleagues. Today we are going to, from the Department of Pulmonary Medicine, we are going to present this CGR on lung transplant, its need and what is the way ahead for the institute in terms of developing a effective lung transplant program. So at the outset, I would just like to say that I will be talking in these headings. What is the need for lung transplant? What are the common indications, contraindications? What challenges can we expect in setting up an effective lung transplant unit, especially in a government setup like ours? So to give a historical perspective, the first lung transplant in the world was done by Dr. James Hardy in 1963. And surprisingly, it was on a jail convict who had a squamous cell carcinoma of his left lung. So the indication for transplant was a lung carcinoma. So although the experience was gained, but the patient lived only for 18 days post-transplant. Now we have come a long way since then, since Dr. James Hardy did his first transplant in 1963, to almost around 5,000 transplants being done till the year 2017 yearly on globally. And the sad part is that out of which almost 90% of the transplants are done in North America and Europe. With India, although an increasing number of lung transplants are being done, they are predominantly done in the private setup. And the first transplant in India was done by Dr. Cherian in 1999 in Chennai. So what is the challenge? So basically, if you see, the survival after lung transplant is very low compared to the other organ transplants because it's a challenging process. And what are these challenges we will come to know in the further slides. So why do we need a transplant? So basically, what is the burden of advanced medically incurable lung diseases in India? So this was an important paper published in 2018 in the Lancet by an Indian author, Dr. Sandeep Salvi. The major findings of this paper was that globally, India contributes to around 32% of chronic respiratory disease related DALYs in 2016, and COPD and ILD are the two major chronic and advanced lung diseases which contribute to a significant proportion of these. So why do we need a transplant? So basically this 2021 guideline serves as a holy grail for us to select the patients who need a lung transplant. And the two basic indications when we should subject a patient to transplant is A, if we find that there is a high risk of death, if the patient doesn't undergo a transplant within 2 years, that is more than 50% of the patients will die if they are not transplanted. And B, if they have a very high likelihood of 5-year post-transplant survival to the tune of 80% if there is adequate graft function. So these are the two basic indications why we should consider a lung transplant in a patient. If both of these are met, then we should consider lung transplant. So without going into the details of indications of each lung diseases when they require transplant, I would just like to enlist the following diseases which are most commonly need a lung transplant in advanced stages. The number one disease which we encounter in clinical practice is interstitial lung disease, followed closely by COPD. Amongst the pediatric patients, cystic fibrosis related lung disease, alpha-1 antitrypsin deficiency, idiopathic pulmonary hypertension, sarcoidosis, cystic lung disease like LAM. In the post-COVID era, we are also encountering patients who have post-COVID ARDS related pulmonary fibrosis as one of the common indications for lung transplant, and post-TB sequelae with advanced and significantly destroyed lung. Now, if you look at this spectrum of lung transplant indications across the last 3 decades, in the decade of 1992 to 2000, COPD was responsible for around 1/3 of the lung transplant, and that spectrum has now changed to almost around 30% of the patients of ILD being the major indications for transplant in the current decade. Now, there are certain absolute contraindications. Without going into detail, the major thing is that lack of patient willingness, advanced and incurable other organ involvement like acute, like liver cirrhosis, patients of renal failure with low likelihood of recovery, active infections are contraindications of lung transplant. Similarly, certain high-risk factors preclude the lung transplant, of which most important being significantly advanced age of more than 70 years, extremes of body weight, and indolent and difficult to treat infections like mycobacterium abscesses or Burkholderia, which are a challenge, especially in the post-transplant period when the patient would be subjected to immunosuppression. Now, what are the different types of lung transplant? So basically, there are 4 major categories in which we would like to divide the lung transplant. Number 1, the heart and lung combined transplant, single lung transplant, bilateral lung transplant, and more recently, there is a concept of lobar lung transplant as well. If you look at the data, the majority of transplants in the current era are bilateral lung transplant because of an enhanced survival. If you compare it with single lung transplant, the median survival for bilateral lung transplant is around 7.5 years, vis-a-vis 4.5 years for a single lung transplant. Hence, in the current era, predominant transplants are bilateral lung transplants. So what do you expect from a lung transplant? A significantly prolonged life of around 7 to 8 years. In some cases, the longest survival has been documented to be around 15 years as well. B, a reasonable good quality of life, no dependency on oxygen. So much so that recently the transplant recipient from India has even climbed to the Everest base camp. So several large centers are reporting the 1 and 5 year survival to the tune of 90 and 80% respectively, and this is bound to increase, especially in high volume centers. So now coming to the process of lung transplant. So basically the process of lung transplant is divided into 3 main phases: the pre-transplant, during transplant, and the post-transplant. So here we have to take into consideration 2 major things. One is a referral. So referral is the process wherein you initiate discussion with the patient to contact with the lung transplant team so that more or less sometimes down the lane he will require a transplant. And listing is another concept where the patient is on the list of lung transplant recipient, and whenever a suitable organ is found, he is transplanted. So these are the 2 processes. Now coming to the pre-transplant workup. So the reason why we selected this topic was the pre-transplant workup involves the backup and efforts of all the other departments apart from pulmonary medicine. So here we require an exhaustive blood workup like the routine CBC, LFT, coagulation profile, electrolytes, thyroid, lipid profile, urine, protein, blood group, etc. Coming to the individual department test, we require a detailed pulmonary function test in the form of spirometry, lung functions and diffusion, arterial blood gas analysis, and a functional assessment with a 6-minute walk test. Our cardiology colleagues are very important because we should know whether the patient requires only a lung transplant or a combined heart and lung transplant. So we need to know the status of both the left heart and the right heart. So we need both coronary angiography as well as the right heart catheterization, because this would determine whether the patient goes only for a heart transplant, only for a lung transplant or a combined heart and lung transplant. Our microbiology colleagues are equally important as well. We need all the serologies like the hepatitis, HIV, Epstein-Barr virus, CMV, etc. We also need the bacterial cultures of sputum to detect any infection. Detailed radiological assessment is also necessary. Here we also need an important backup from the nuclear medicine department to help to rule out any occult malignancies in the donor, which would again preclude the lung transplant. We need a transplant immunology workup in the form of detection of HLA antibodies by panel reactive antibody status, which helps to estimate the risk of rejection post-transplant. We need our gastroenterology colleagues to do the 24-hour pH study as well as upper GI endoscopy to detect any signs of aspiration, which again accelerates the post-transplant rejection. And other departments like Gynac, ENT, you need the endocrine bone mineral density workup, dental assessment. Psychiatry workup is also an important aspect to see whether the patient is willing for a transplant. And of course, the department of PMR would play an important role by giving an effective exercise rehabilitation program, both in the pre and the post-transplant period. So, as I said, the reason why we selected is to to emphasize that we need all the departments of the hospital in some capacity or the other to make our transplant program a success. Although the backbone of the transplant program is the pulmonologist, the anesthesia and critical care, and the surgery team, all other departments play an equally important role. So coming to the ideal donor, so basically who can be an ideal lung donor? So I just want to make it clear that we do only cadaveric lung transplant. It's possible only in a brain dead donor. It's not a live donor. Donation is not possible currently. And an ideal donor should ideally be around 55 years or less. He should be a non-smoker. He should have ABO compatible blood group. And there should be no significant chest trauma, aspiration or sepsis, nor any pre-existing infection in the donor. So what are the major obstacles? So we have done an extensive workup, but still, if you look at the data, only 20% of the donor lungs are deemed to be suitable for transplant, whereas this figure is to the tune of 88% in liver and kidneys. Hence, the survival as well as the success of the program, in spite of all the efforts, is less. Cost. So cost, I would just like to highlight. Currently, if you look at the cost in private setup, it is coming to the tune of 50 lakh, with almost 5 lakhs being required for the pre-transplant workup, 30 to 40 lakhs for the inpatient care, and almost around 10 lakhs for the post-transplant care. We need, obviously, the backbone of our team would be a good transplant surgeon, without which we cannot even think of starting the program. Obviously, we need public awareness programs, because right now, if you see, the majority of the organ donations takes place down south as compared to the rest of the India. So we need effective awareness programs as well. Now coming to the post-transplant care, it's a fine balance between infection and preventing rejection. We need a lot of medications which the patient is to take post-transplant, like triple immunosuppression, prophylaxis against various infections like CMV, fungus, PCP, osteoporosis, and aspiration prophylaxis. We need our intervention pulmonology team to be strong, because we need to do a thorough airway evaluation at periodic intervals in the form of rigid bronchoscopic assessment if needed, for placing stents, doing dilatation. So we need an effective interventional pulmonology team as well. So what complications do we expect in post-lung transplant? Majority of the complications we deal with are related to infection or rejection. Certain other complications like bronchiolitis obliterans and anastomotic dehiscence related to surgery are also encountered. So how do we, finally concluding my seminar, what do we require to set up a transplant unit in a government setup? Number one, I would say, is that we require an effective administrative will and support. We need trained manpower. That is an most essential, and we need coordinated efforts by all the departments to ensure its success. The dedicated transplant team should be available round the clock, because effectively around 6 hours is the time which is available whenever a patient is brain dead for retrieving the organ, and that is crucial, because more the delay, more are the chances of post-transplant rejection. We need to create a proper pool of recipients. So basically there is something called as lung allocation score, which is followed in the West. There is a pool of patients who are assessed for the severity of underlying lung condition and what is the urgency for transplant. So that pool of patients is necessary. And finally, financial support, both for the pre and post transplant care, is necessary initially for the patients, so that they are able to withstand the cost of costly medicine. So to conclude, lung transplant is a need of the hour, especially for our end stage lung diseases like ILD and COPD, where no medical treatment is available. The process of transplant needs a coordinated efforts by a number of departments, and its availability in our setup is the only ray of hope for poor patients who cannot afford costly transplants in private setup. And we need a dedicated and round-the-clock functioning lung transplant team for effective results. So I would like to conclude by this: there will be obstacles, there will be doubters, there will be mistakes, but with hard work, we surely can set up an effective transplant unit. Thank you. there are any questions, be happy to take.
How do you assess the lung functions in a brain dead patient that this lung is good for transplant and which lung is not good for transplant? What are the criteria?
So basically, sir, the criteria is a bronchoscopic criteria. So basically, we have to do a whenever you get a call for a brain dead person when we have to assess for the suitability. What we do is we have to examine whether there is no chest trauma, no rib fractures, lung contusion. We do secondly a bronchoscopic examination to assess the airways, that there are no purulent secretions, no signs of aspiration, and we take a bronchoalveolar lavage and send it for cultures to see whether there is no pre-existing infection, and we see the oxygenation status of the patient. If the PF ratio is good, he is maintaining adequate oxygenation, he is, according to us,
good means how much? More than 300?
More than 300, yes. I have mentioned in my slide. PF ratio more than 300 at FiO2 of 100 and PEEP of 5. So he should not be basically requiring a significant proportion of oxygenation.
And the other chronic respiratory disease we rule out with the help of history and the radiology.
Yeah, history radiology is something different, but patient may still have slightly raised PA pressures, so which may not be very easy to diagnose.
Nice presentation, Dr. Hari Haran. My question is that for recipient, is there any criteria regarding lung functions? For example, in CF, we do use FEV1 less than 40%, then this is not a candidate for lung transplant. So is there any criteria for adult also?
No, I mean, so if you have a bad lung function, that itself is a criteria that you should need a transplant in terms of recipient.
But is there any lower limit? Suppose lung function is below this lower limit, then we cannot do transplant.
No. There is no lower limit. So because in COPD, the criteria is if you have an FEV1 of less than 25% also, he needs a transplant. So there is no absolute lower limit. Yeah, there are disease-specific criteria. So if you look,
chances of rejections are more in that way.
I mean, the lung function is not a criteria for rejection, or patients who have a bad lung function are themselves a criteria.
That is rather indication.
Yeah.
But Dr. Jagdish asked me, what are the criteria for selection? Is there any criteria?
There are disease-specific criteria, ma'am. There is a criteria which is different for ILD. The criteria is different for COPD. It's different for pulmonary hypertension. Every disease has a different criteria.
Dr. Hari Haran, thank you. And this is a good step forward from your department. And because lung transplant require cadaveric program to initiate, and here we are in the process of cadaveric transplantations.
Okay, sir.
So question is that in the direction of transplantations, much more important thing is we should know what are the pattern of disease in our setup. So what are the type of ILDs? How these patients are developing ILDs? What is the load of ILD in our OPD patients? What are the etiopathogenesis of these ILD? Are we able to control it on the community level? Okay. Because transplant, as you highlighted, with the cost of more than 50 lakh, it is not an easy thing. And the way the infection is there, the way complications are there, that is much more robust system we need to develop to face these challenges, not from the financial point of view, but from the infection point of view and the way to handle the primary disease that contribute for the end-stage lung disease. So what is your OPD data? What are the burden of these patients which require actually the lung transplantation?
So that's an excellent question, I would say. So coming to part by part, so what is the data of ILD in our patients? So when I joined around, say, 1.5 years back, we used to get around 30 patients of ILD. We have a dedicated ILD clinic. So we used to get around 30 to 40 patients of ILD. Now that number has increased to around 120 to 130. I mean, 30 to 40 patients were there in our pool. Now that number is easily crossed to around 200 to 250 patients. On an average, we do get around 5 to 10 ILD patients daily in our OPD. A significant proportion of these ILD in our setup is due to chronic hypersensitivity pneumonitis, I would say. And the major contributor for this is, organic matter, decaying organic matter and pigeon exposure. So if you ask the etiology, so that is the major contributor of ILD in our setup, that is chronic hypersensitive pneumonitis. In the West, if you look at the data, it is idiopathic pulmonary fibrosis probably. But in Indian setup, majority is chronic HP. The second question was, yes, we do need a robust, a trained and dedicated lung transplant team prior to doing a transplant because of the cost issue that is to the tune of 50 lakhs. So that is why that was the exact idea why we wanted to do this CGR in terms of lung transplant, so that we have everyone on board and we can, initiate the discussion and, start the process of lung transplant. So that is what is our data. So significant proportion is ILD and chronic HP, chronic hypersensitive pneumonitis.
Because one important thing I want to add here is that even for renal transplantations, because most of the time we go for the renal transplantations and young patients we often select. And even when we take this patient, the 5-year survival of such patient is around 60 to 70%. And when we look for the 10-year survival, that is around 30 to 40%. So even after the long follow of these patients again land up into the second transplantations.
Yeah. Even it is same for lung transplant. So after 10 years, bronchiolitis obliterans syndrome is bound to develop in all of these transplant patients. And that is a major reason for a retransplant after 10 years. So same is the scenario with us. But at least the good, our patients, are there 24/7 dependent on oxygen. They can't even do their basic things. So transplant is the only way where they can, lead a independent life. So it's must that we do it. And even in our patient, the majority of the age group is 40 to 50. And that's, sort of a productive age group. So transplant is the only ray of hope for them. So.
Just to add in the final comment of mine, we should always in an active effort to try to find the causes of ILD and try to handle it also, because these are the primary thing we need to focus more.
Exactly.
That is the one addition.
Not for ILD or any respiratory disease, for throughout the medical science, the prevention is always better than cure. The primary care, then the secondary care, lung transplantation, or for that matter, any transplantation should be last option for any disease. But the thing is, many of the ILDs, they are idiopathic. Secondly, especially in our setup, most of the people, they present very late. They are on oxygen. So I totally agree that the prime focus has to be on preventing the disease in the society. But again, we need a program, because still, even after doing a lot of effort on the primary care, we'll still be getting many patients who will require lung transplant.
Harian, it's a nice presentation from your side and Department of Pulmonary Medicine. And from the Department of CTVS, I can say that we are very in advanced stage of filing our application for the transplant of heart, lung, and lung transplantation. Cadaveric donation as well as the but other tissue like an aorta and other heart walls, where we are not using donor heart for the heart transplant. And trachea also will probably harvest, so that trachea can also be used for the various other diseases where lung and trachea is not used as a organ recipient. The other issue is the financial issue which sir has raised. Financial issue in Chiranjeevi scheme has been lot consideration has been given about it, and we prepared financial assistance program from our side only. We tried to add up to 25 lakhs and more if earlier government has promised us. So financial angle can be taken care by them. It's not just surgery or one person's work. It is a lot of work where the pulmonary medicine takes a lead role, where they'll select the patient and they'll after surgery care also. Yeah. So in tandem, if we work, then probably we'll have a successful program here. And you are right that a dedicated team is required, but dedicated team, sparing a team and the team keep on waiting for the donor to have a transplant in the recipient is not feasible right now in India. So that's how this dedicated team idea is not implemented throughout in India as such, because there is no legal support where the automatic donation, automatic organ donation from the brain death patient is considered. Few countries where the like a prisoner or if somebody has given a will in his lifetime that he is an organ donor, then they do not require after death other people's intervention. So there these programs are more successful and they have these dedicated team ready every time, so they can fly and harvest the organ and come and transplant within 6 hours. Organ donation support systems are also being developed where the live organ from the harvested from the cadaveric body can be survived longer time by perfusing them with a special fluid, so that they'll ischemia time will be prolonged and up to 12 hours we can transplant them. So at time we feel frustrated that why is not happening here, and 200% in our OPD are requiring transplant, but supply and demand is very huge here. Gap is so huge that everyone feel palpable, and in that picture we come where the legal and permission issues and administrative issues are still not conducive.
That's
We are
absolutely
not,
right.
if we have today ready a donor and you have a ready recipient, but without legal assistance and proper clearance, we are not able to transplant. Even if we have a donor here in this center, but if SOTO allowed that organ to other center, then that's our center will not have right to transplant it. So there are the lot of legal hassles also is there in our country. So let's see, we'll fight with each and one and solve and find solution for them.
Nice presentation, Dr. Hari Haran. Just a comment regarding the selection criteria on the patient. In perfusion, lung perfusion scan, in literature it is mentioned that if the differential function difference is more than 31%, then the prognosis is bad. So your take on this, do you consider this criteria?
Not really. It's not there in our, if you look at the ISHLT document, it does not specifically talk about this differential perfusion as one of the criteria for rejection. But obviously, when we start a program, we would definitely like to look into it and, take you on board before we see whether they can be actually taken for transplant. Right now, from the nuclear medicine, we also require PET scan. That is one more thing where nuclear medicine support is required to detect any occult malignancies if the donor is having. So that forms one of the pre-transplant workup. So with regards to the differential perfusion, we would definitely, once we start the program, we'll look into it.
Congratulations, Dr. Hari Haran, Dr. Naveen, and Department of Pulmonary Medicine for leading this talk on much needed service of lung transplant at our institute. Since you highlighted that the much of the work in lung transplant in India is happening in the south and that too in the private field, can you update about what is happening in AIIMS Delhi and PGI some years back performed lung transplant? Okay. What are the obstacles these institutes are facing?
So, thank you, sir. With regards to lung transplant in government setup, when I was in AIIMS Delhi, there were actually 2 transplants which happened in AIIMS Delhi. Both of them are doing well. That is what is the feedback I've got. PGI, 1 transplant happened, but the patient could not make it because he had a Burkholderia infection. So that was, it's kind of indolent and chronic, difficult to treat infection. So right now, AIIMS Delhi has a program in place. They have a list of potential recipients who are residing around Delhi. So that is one more challenge in government setup. So we should ideally have our recipients in and around a particular area so that they can be called any time of the day whenever there is a donor available. That is one challenge. Second challenge which I feel we were facing when in AIIMS was, when there was a call for donor. So how we would be transported there in terms of like if they are residing really far, and also taking our equipment, like we need a portable bronchoscope for taking it to that institute to assess the suitability of the donor, and also availability of a microbiology team in the night to give us the report of the gram stain, the cultures, to see to select the appropriate donor. So these are some of the challenge. Of course, financial challenge was there, but in AIMS Delhi, at least one good thing was for the initial 10 transplant, the hospital had supported a grant of 10 lakh for each patient for both his pre-transplant and post-transplant workup, which includes his immunosuppressive medications. Because around in the first year, he has to bear a cost of around 20 to 25,000 per month for only his immunosuppressive and antibiotic medication. So the institute funded around 10 lakh per patient for the first 10 transplants. So these are some of the aspects of transplant in government setup. Apart from that, I don't think anywhere they are doing right now.
Do this Ayushman scheme is having any cover for lung transplant?
Right now, I think they are not having directly. Some in some states.
So there was one proposal up to 25 lakh, but that has to be done in the Rajasthan state only.
No.
It was in.
I'll update it because Chiranjeevi's nodal work is done by me. So here in Chiranjeevi we can have a transplant where the packages are for the pre-transplant and during the transplant and after transplant workup, and then every yearly he can be renewed because his insurance will be renewed, so his treatment will also be covered. So there are the 4 packages made for the transplant here in Rajasthan. And second thing, like an other support, like an ECMO support during the transplant is also covered under the Chiranjeevi scheme. But that was in a past thing. Now is an Ayushman scheme. Ayushman scheme is a central government scheme, and Rajasthan government and central government is still not done any MOU. Still our Rajasthan new government also is not done the MOU. So our patients are still not getting a benefit of Ayushman right now in Rajasthan. And Ayushman scheme doesn't cover any organ transplantation.
Okay.
Thank you, sir.
Thank you, everyone.
Good.